So scoliosis, which is a term that unfortunately a lot of our patients think they have or they throw around all the time, is really a curvature in the spine, whether it is in the lower back, mid back, or the upper back, or the neck. Really, it just means curvature in the spine. In adults, scoliosis is mostly how their alignment looks when you look at them from the side. In the pediatric population, mostly we're looking at scoliosis in terms of their coronal deformity, meaning how does the curvature look when we're looking at them from the front. So really, scoliosis has different definitions depending on which age group we're talking about, and there's definitely different treatment options for each of those. Well, because there is a normal variation of within normal range, there can be some curvature in the lower back or in the mid back. It's really not, when you look at our textbooks, it's not called scoliosis until there is at least 20 degrees of curvature in the lumbar spine or thoracic spine. So you may think that you have a little bit of a curvature, or your second grade teacher told you may have scoliosis, but when we look at the x-ray that we get in office, we may not have those measurements that define that curvature as a scoliotic curve. So that's why I say, scoliosis is a term that a lot of people throw around, but it's, a lot less people have it than they actually think. Scoliosis in the adult population can come about because the spine starts wearing out asymmetrically. So a disc on the left side might have more pressure on it and wear out quicker than the disc on the right side. So now you're all of a sudden tilted to the left side. So you have that's called adult degenerative scoliosis versus adolescent scoliosis. That's a scoliosis we typically see in the younger population. Scoliosis, typically, yes, you can actually look at the patient's overall alignment as you're looking at them from the front or you're looking at them from the side. But the best way to actually look at the overall alignment is to obtain scoliosis x-rays. So we get a full-length x-ray, which we can actually do in office, that allows us to see the spine from the front, if there's any curvature to it, and then also from the side. And we look at some of the parameters that actually allow us to determine whether or not your alignment is fit or not, your sagittal alignment, how it looks. So we look at, for example, how much curvature do you have in your lower lumbar spine? And does that match with some of the measurements we have from your pelvis? Does that match with some of the kyphosis or the opposite curvature from the thoracic spine? Does that match from your cervical lordosis? So all these curvatures, basically looking at an adult patient from the side, we obtain our scoliosis x-rays and we make those measurements and see, does it meet the definitions that we consider scoliosis or not? We have to look at the severity of the symptoms and look at what treatment options are available. There's always a risk and benefit analysis. It's how bad are the symptoms, how bad is it affecting your quality of life, and can surgery correct the problem or get rid of all the pain? And that's a discussion that you have to make it individualized to the patient. Look at their curvature, look at what they have done, look at what other options they have. And if they have exhausted everything else and you're pretty certain that the majority of their symptoms is coming from their scoliosis, then surgery is an option.